Dr. Okello was so gracious to bring a bag of potential therapies. So I want to bring that bag out and I want to go over what's in the bag of therapies for pediatric asthma.
This is a model that I've found incredibly useful, and in general, I find visual aids helpful to patients. Otherwise, they're just listening to me ramble on and on. But this is a healthy kind of picture's worth 1,000 words. And so I've two types of airways here. The first airway is the inflamed airway that you referred to, kind of swelling of the airway lining and overproduction of mucus. And if we compare that to the non-asthmatic airway, we can see that this inflammation narrows the passageways, which is what you were talking about. And really that narrowing is what translates to symptoms. And so we have to think about the right medicines to reduce or eliminate this inflammation, as you know and have talked about already.
Remember, you guys, the kid's airway is already narrower than an adult airway. So you're dealing with an airway that's already tighter in diameter. And so now, if you put asthma on top of that airway, their symptoms are going to be probably more severe. They may not say anything because they're kids, but that's the worry here.
The other component, which we touch on, which I think people are far more familiar with, is this muscle that surrounds the airway that can tighten or contract, what we call bronchospasm. And this is what everyone's rescue inhaler works on. So people often live and use the rescue inhaler all the time, probably too much, which works on this muscle but does nothing about the inflammation. And as we know, when you're in that situation where you're relying on just relaxing this muscle instead of treating the inflammation, you will still get into trouble.
And that's another important point to think about is when you look at albuterol, short-acting beta agonist, these individuals that rely on just albuterol during an asthma attack, right? When somebody's having wheezing, when somebody's having coughing, shortness of breath acutely, the more you use albuterol, actually, the higher your mortality, the higher your morbidity, because albuterol does not address the foundation of what your problem is, which is the inflammation. It only addresses the bronchoconstriction, but you're being bronchoconstricted secondary to the presence of white blood cells in that area that are causing that muscle that Dr. Okello just described to contract, to start tripping. And that's the problem when you're not seeing appropriate specialists, or when you're not truly understanding what your illness is you're continuing to use albuterol to treat inflammation, and it does not, absolutely does not do that. In fact, so much so it does not do that, that the global strategy for managing asthma has actually changed in the last 8 months. The global strategy now says anytime you take albuterol, that short-acting rescue inhaler, you need to take an inhaled corticosteroid. And that's not only in adults, but it's also in kids, right?
Absolutely. Absolutely. If you find that your albuterol, your rescue inhaler is not working, it's because of what Dr. Rutland just said. You're not treating any inflammation at all, and it's rendering your inhaler useless.
You got some other toys on the table.
I do. Earlier, we talked about an adequate trial of therapy, so taking medicine the right way. And there are a few devices that are helpful or important in that. The first for any type of inhaler is to use a chamber that we refer to as a spacer. Whether you're 6 months of age, a teenager, a young adult, an elderly, a senior, these spacers are critical in maximizing the delivery of the medicine to the target, which is the lungs, but also in terms of avoiding side effects. Patients always ask about side effects. What's a side effect? And that's appropriate. Well, these help limit some of those side effects, whether it's from your rescue inhaler, such as getting a rapid heart rate, or your inhaled steroids, such as getting thrush. These are helpful for that.
Do you recommend that for all of your patients? Using a spacer?
Absolutely.
No matter their age?
Absolutely. And so there are spacers. I held up a spacer with a mask, which typically we use in children who are under 5 years of age, mostly because when we give the inhaler, we just let them breathe in and out with the mask in place on their face. They're a little bit too young developmentally to coordinate what we do with the other spacer, which is to take a slow, deep breath and hold it for 5 seconds. So the child has to be developmentally able to follow those directions. And so even for some older children, if they're not able to, we'll use the spacer with a mask. But yes, every child of any age gets a spacer. And like I said, the younger children will get a mask.
And then you have is that a nebulizer?
Yes.
It is really not cool to carry around a spacer, doctor. So I'm assuming you're teaching your teenagers or adults how to use the inhaler by itself. I thought it was interesting that you said they might have more side effects. I feel like that might be motivating to use the spacer if I haven't heard that before.
Absolutely. Thank you for bringing that up. Yes, in terms of kind of total care, which is what you're talking about, is recognizing what the barriers may be to the patient or the family following the treatment plan. And it is actually very important to recognize that peer pressure among our teenage patients in particular is a factor, and absolutely using a spacer in public is not cool at all. I think there are two solutions around that. One is if they are taking their daily anti-inflammatory, that can be done in the privacy of their home. So ideally, that's an incentive for them to take the anti-inflammatory so that they don't have to use the spacer with the rescue inhaler in public. So that's one. But second is in 2025, there are so many different asthma medicines that are out there. There are asthma rescue inhalers where you don't need a spacer. So it helps the provider to be creative in recognizing, well, how do we best put this patient in a position to succeed and follow the treatment plan?
Can I see that spacer? One of the things I've always thought, and again, can you imagine if this spacer was a Supreme spacer, or this spacer was a Nike spacer, or this spacer was a Louis Vuitton spacer? Like, I always felt like big brands like that could get in on this, and that would incentivize these high school kids to use their medications because it's cool. Like, I mean,
Genius.
that's what I would do.
Yeah.
Like, if I were Nike, if I just put a swoosh on this thing, maybe made it white, I mean, just making it look cool, then all your friends that have asthma are like, I want that spacer. And then they look cool. Like, that's the marketing campaign that I would employ.
I think that's an excellent point, and I would take it a step further. I think that there's an opportunity for any one of these companies to identify prominent athletes to start with who have asthma. The number of athletes who have asthma is much higher than people realize. I think over the past few years, we've had to learn, unfortunately, about some famous athletes who've died from asthma. Recently, Ricky Henderson being kind of the most recent, who suffered for a long time from asthma. And, again, just to highlight the importance of this podcast, asthma is such a totally treatable condition. No one should ever suffer from it, let alone die from it. It's really, honestly, inexcusable. So there is a great opportunity for famous people with asthma to be identified, hopefully, and encourage and make it cool to use a spacer for greater good.
The 100-meter gold medal winner from the United
Noah
States.
Lyles.
Noah Lyles had an asthma attack right afterwards. I mean, can you imagine lifting this up? Nike swoosh, like, get out of here.
Absolutely.
Like, what is that? What are we missing here?
Yeah.
Yeah.
And if you guys need help designing it, we're all here to help you.
We are.
We'll just take a small percentage.
Totally. To round out the discussion that we're talking about, you mentioned a nebulizer, which most families with children with asthma are well acquainted with. This is a machine that creates a mist out of the medicine, and the child breathes it in. There are really two ideal ways that's done. I have one example here, and that's what we refer to as a mouthpiece. Any child, typically 5 years of age and above, should be able to use this mouthpiece. There's some tubing that connects from the machine to here. The medicine is placed in what we call a cup, and then the child holds the device in their mouth for the full duration of their breathing treatment. If they're too young, say they're a toddler or an infant, then there is a face mask that can be attached here that's held into place with some straps. Those are the two ways to utilize this nebulizer to optimize delivery of the medicine to the lungs. Some parents will just take the tubing and hold it by the child's face, what we refer to as blow-by, which is totally inadequate. So again, we talked about an adequate trial of therapy, the right medicine taken the right way. So we're talking about how to take the medicine the right way here.
So again, when you look at the general management of asthma, pediatric asthma even, you're going to use an inhaled corticosteroid daily, at least. Your rescue therapy, you want to be albuterol with an inhaled corticosteroid when they take their albuterol. And then you're going to up titrate the dose of inhaled corticosteroid. You might add other controller medicines like a leukotriene receptor antagonist. And then you might add, a long-acting muscarinic antagonist in some cases. If patients continue to exacerbate, I'd be remiss if we didn't mention, because of the immunology of asthma, which we understand, right? We understand the messaging molecules that are involved in recruiting the white blood cells into the airway. We call these molecules cytokines. We can use certain products. You kind of mentioned it earlier. You said biologics. What are biologics? What did you mean?
First I'd add what you've just highlighted very quickly is that there are a full complement of medicines out there to manage asthma. Again, there's no reason for any patient to be suffering from asthma. The kind of newest on the scene, although one of them's been out for 20 years, the others have come online in the last 10 years or so, are these injectable anti-inflammatory asthma medicines that may be given anywhere from every 2 to 4 weeks. And they are intended for the patients who have gone through the other complement of medicines that you ran through, but yet are still suffering from asthma attacks, requiring prednisone or going to the emergency room and so on. As you know, this class of medicines that we call biologics have been a total game changer for those patients on the severe end of the spectrum, and really have been life-changing. And it's hard to imagine kind of managing patients without this class of medicines.
Obviously, Dr. Okelo is at UCLA. Obviously, Dr. Livingston is at Miller Children's. I find my way to stay in touch. But for individuals that are out there in community practice and not as in touch as we are, what advice would you give them to sort of stay up to date, at least with asthma management?
Pediatricians have a conference every year. The American Academy of Pediatrics has a conference. It really is one of the best ways to stay up to date on changes. And there are, American Academy of Pediatrics newsletters. So we get updates on every subject imaginable. You have to make the time to look at those things, but a once a year conference, I think, is an easy way to consume a lot of information in a short period of time.
Thinking about creative strategies to help physicians help themselves. So one example I'm thinking of is actually on the table. We've got a little poster that says respiratory treatments. And this is a great way on keeping up to date with the treatments that are out there. It is a great way to have a discussion with patients about medicines they've used or medicines that I would like them to use. So, one example of a tool that can help physicians help themselves, navigate those asthma waters, if you will, with patients.